Mark Romsek,
Recording
orthopedic surgeon. Okay, that's good. Orthopedic surgeon here at Baldwin, and I've been here for about 2.5 years now. Prior to that, I spent 5 years down in Viroqua, which is a small town about an hour south of La Crosse. And prior to that, my whole life was spent near Detroit, Michigan. What I'm going to talk about, has anybody been to one of these before? No. I know we have a lot more people that are supposedly coming, but maybe the weather's keeping them back. I don't know. What this talk, I've given this talk quite a few times, and it can last anywhere from a half hour to an hour, depending on how many questions you ask. And feel free to ask any questions. I narrowed it down to this topic just to stay on track on something, and this is a pretty common condition. And I gear it toward the knee mainly, because I do a lot of total knee replacements and I see a lot of knees. But this can correlate with shoulder arthritis, hip arthritis, really any joint in the body. So I'll get started here. Generally speaking, there are two main types of arthritis. You've probably heard of rheumatoid, and you've probably heard people say osteoarthritis. Well, the big categories are the non-inflammatory and the inflammatory. And that's what we learn in medical school and through residency. The non-inflammatory is your osteoarthritis. The problem with this, describing it this way, it gets confusing because arthritis can cause inflammation. So it's really not non-inflammatory. But how they name them is what causes the destruction of the joint. That's what they're gearing that toward. So in other words, the non-inflammatory or osteoarthritis is more wear and tear of a joint, or joints that have had injury in the past. Maybe you broke a bone or something like that, and the joint is not so perfect anymore. And as time goes on, it wears out. Much like a piston in a car engine, if you don't have that perfectly centered, and if it's off a little bit, or there's not any oil on one side, it can wear down that engine and cause that engine to seize. So if our joints aren't nice and perfect, that'll wear down and it'll cause arthritis or the destruction of the cartilage on the end of the bone, and we'll get to that in a second. So that's your osteoarthritis. The big category of non-inflammatory is mainly osteoarthritis, trauma-related wear and tear. Okay. When you get that, what has caused the destruction of the joint is a non-inflammatory process. So your trauma, your wear and tear. When you get that arthritis, though, the reaction to the arthritis is actually you couldn't have inflammation. So we're looking at this like what comes first, what causes the destruction of the joint. So then the second main category is your inflammatory. So this is your gout, your psoriatic arthritis, your rheumatoid arthritis. These are conditions that the body is kind of attacking itself. So the joint lining that all joints have can become almost like acidic. And the synovial fluid can become counterproductive. It can have things in it that break down your cartilage and break down the joint. So the inflammation that's being caused by the autoimmune attack on the body's joint is causing the problem. Okay, so that's why they call it the inflammatory type of arthritis. Does that make sense? Anybody have any questions about that? So when we look into treatment, and we got slides coming, but sometimes I deviate into it and out of it, but the inflammatory or the autoimmune or the body attacking itself can sometimes be treated with medication. So you want to hit the body with some medication that decreases the body's making that bad acid-like environment. So sometimes that can help. psoriatic arthritis. Anybody know Phil Mickelson, the pro golfer? You've probably seen commercials of him. He's advertising for a certain medication. So he was a he still is a pro golfer, and he has psoriatic arthritis. So he had the inflammatory condition where the body unfortunately is making this bad joint fluid, and it's causing destruction of the joint and causing pain. Then he took medication, and that made it better. So it decreased that autoimmune attack on his joints. So as far as I know now, he doesn't need any joint replacements or anything. He's able to play golf comfortably. So if he hadn't taken that medication, it probably would have ruined his career. And then, so the non-inflammatory, again, trauma-related, wear and tear, the inflammatory, kind of autoimmune, the body attacking itself. The end result, both of these conditions are going to have inflammation. It's just, again, what started it and what's causing it. So both of these can do well with non-inflammatory drugs, your NSAIDs, ibuprofen, Aleve, Celebrex, things like that, or even injections into the joint. People have heard of cortisone shots and so forth. So what is arthritis? Arthritis, it can attack any joint, and a joint is anywhere where you have part of your body moving. So obviously the knee, the hip, the ankle, little joints of the fingers, the hands. So anywhere that needs to move relative to another. And the end of the bone has cartilage. And that cartilage sometimes can be as much as half an inch thick, real thick cartilage. And that cartilage on the end of the bone is not much different than if you've had a chicken leg, turkey leg. You look at the end of it and you see that glistening white, real slippery stuff. That's articular cartilage. So on the left, that's an artist's rendering of it looking very healthy. So it's nice and smooth. In real life, it looks like a cue ball in pool. Nice and smooth, and kind of whitish. And then when it starts degrading, it starts getting pits in it, or cobblestone appearance, potholes in it, like on a road. And that's the wear and tear. This could be from osteoarthritis. It could even start looking like that from inflammatory arthritis, like rheumatoid, psoriatic, gout. Basically, you're just looking at the cartilage, and if it's starting to be destroyed, that's arthritis. Now, how it got that way, you got to try to figure out. Is it from a trauma? Is it from wear and tear? Is it from one of the inflammatory conditions? So when you go to the orthopedic surgeon or your primary care doctor, and they first want to order an x-ray. So you want to evaluate the patient, find out if they have swelling in the knee, if there's any deformity of the knee, what their range of motion is, and so forth. And then you want to get x-rays. And the x-rays tell a lot about the condition of the joint. So when you get a regular x-ray of like a knee, the bone shows up, but the cartilage does not. Cartilage is radiolucent, which just means that the x-ray doesn't pick it up. It goes right through it like there's nothing there, like air. So this on the left, as it's labeled as a normal knee, you see the femur, or the thigh bone, and then you see the tibia, the shin bone. Here's the fibula, the strut bone that's on the outside of your leg. The space in between the tibia and the femur is not just air, that's cartilage. So this has some good spacing. The more black spacing you see, the more cartilage you have. So that's what we're looking for to diagnose someone with arthritis. And then the x-ray on your right, you can see that this patient has a lot of arthritis in this area because it's collapsed because they no longer have that glistening white thick cartilage on the end of the bone. This is pretty much approaching bone on bone. You've probably heard that term. I've got bone on bone arthritis. That means that that cartilage cap is pretty much gone and all you have is raw bone, which causes a lot of pain. You can also get a deformity. So this compartment right here, this area of the knee, is on the inside of the knee. So it's the part of the knee that if you put both of your knees together, your legs together, they touch. That's called the medial compartment. The outside is called the lateral. Most arthritis starts in that compartment because 60% of our body weight normally goes through that area. So if you're going to get wear and tear, it usually starts there. When that happens, and it continues to degrade and degrade, and the worsening of arthritis, you start getting bow-legged. I'm sure you've seen people walking around where they're completely bow-legged. Very, on occasion, not very rarely, but less common than this is just on the outside, and those people walk around knock-kneed. But usually people, when they get arthritis, it starts on that medial compartment, and they end up getting bow-legged. And this next slide shows that. So you can see on the left side, her right leg is nice and straight. You can see the bow to this leg right here. And that's because this patient has arthritis, mainly confined to there. Did I touch something? It's not touch sensitive, is it? Let's see if I can. So sometimes when I'm shopping with my wife and getting bored, I don't like to shop, I make fun and games out of it by looking at the people walking around. I say, well, he needs a right knee replacement, they need a left knee replacement. You can also tell certain things about hips too, because some people do this, it's called a Trendelenburg gait. So they always kind of fall to the side that's weak, and you can kind of deduce what's wrong with them too. So if someone's in front of us and walking, like my wife now already says, don't say it. Okay, the treatments. We already kind of talked about this a little bit. So the way that I look for treatments for any condition is I use an analogy like a ladder. And nobody goes up to a ladder and jumps on the top rung. You can't do it. You go rung by rung. And so you start from the ground. And then as you go up the ladder, you're getting more and more invasive type of treatment. So we always start at the ground level and try to make you feel better by the least invasive method possible. Sometimes that's diet and exercise, physical therapy, maybe some over-the-counter anti-inflammatories, NSAIDs like your Aleve, Advil, ibuprofen, Motrin, things like that. And then you can work your way up as you need to. So the big difference is the inflammatory arthritis, such as rheumatoid, psoriatic arthritis, gout. Those you can take certain medications. And specifically for rheumatoid, people have taken gold, methotrexate, infliximab, Anacept. Those are different drugs on the market for those conditions. Who's ever had gout? Anybody here? You can be put on colchicine, indomethacin, or some people take allopurinol lifelong, and that's to try to prevent a gouty attack. And that can destroy any joint in the body too. Your osteoarthritis, again, non-steroidal anti-inflammatories. This stuff is more like the GNC homeopathic ginger and boswellia. I just put that in there to be complete. There's really not a lot of research done, but that's kind of like the the homeopathic type of things that you can take, natural supplements and things like that, that some people claim makes them feel better. Then you can work up, as you work up the rungs of the ladder of treatment, injections. In both cases, you can do injections of cortisone. Cortisone is a steroid, but it's not an anabolic steroid. It's a corticosteroid, it's called. Anabolic steroids are the steroids that Lou Ferrigno and Arnold Schwarzenegger took to get huge muscles. But the steroid that we inject for arthritis is a high potent anti-inflammatory. So some people that have problems with breathing, be it from any kind of inflammation that might be happening in there, pneumonia and so forth, some of those people are put on steroids to decrease the inflammation and help them breathe. Okay. That's a similar type of steroid that we inject right into the joint that's painful. It doesn't get rid of the arthritis. It doesn't stop the arthritis, but it's used to decrease the inflammation and hopefully make it feel better. There are other type of treatments that you can do. This patient, let's pretend that she's 30 years old, was a professional skier, and had a fracture of her knee. Or let's say she tore an ACL, and she developed arthritis, called post-traumatic arthritis. This means after an injury. Remember I told you about the car engine? If it's off a little bit, it can wear much faster. So that could be an example that she had either a fracture or an ACL tear that threw off the mechanics of the knee, caused it to wear down, and she's left with this and has a lot of pain. And let's say she worked her way up all the way up the ladder of treatment, and now she's going to the top rung, which is surgery. Well, in someone that's 30, you really don't want to do a complete knee replacement because they will have some restrictions on what they can do. And besides that, knee replacements only last so long. They can last up to 25 or 30 years. But in someone 30, they're definitely going to wear it out. So there are other options to do. They don't sound that great, but they've had some success, and that's called an osteotomy. That's why I put that up here. What they do is we can cut this bone and purposely cause a break, fracture, realign it, and then put plates and screws in there and let it heal. And so what we're doing is we're getting rid of most of the weight coming through this area that might be arthritic and painful and moving it to the other side. Typically what that buys is maybe somebody 5 to 7 years. So hypothetically, if this patient comes to an orthopedic surgeon, I'm a pro skier, I want to do it one more time, I want to try to make the Olympics one more time. That would be something that you could do so that they could try to make that the team, so to speak. So, but what that does is, and why it's only 5 to 7 years, is because you can imagine that if we realign this and then put most of the pressure here, it's going to start wearing out that side. And then you're going to have to convert it eventually to a knee replacement. You're hoping that, it can last as long as possible. Maybe they try one more time. If they make it, they make it, and then they just decrease the amount of stress that they're going to put through the knee.
Can that be done with other joints as well, or just the knee?
Mainly the knee. There are some times that they can alter the mechanics of your hip for certain reasons, but for basically the main joint that you can do this for is the knee. Now, another type of treatment is bracing. So you can get what's called an unloader brace, and what you can do is it's kind of bulky, it's long, and it's hard to put clothes on over it or under it, but essentially what you're doing is you're realigning this leg with a brace, an external brace, rather than breaking the bone and doing it internally. So you could put a brace on here that would theoretically open up this part of the joint and put more pressure on this side of the joint. You can imagine if I put a brace on you to do that, it might be pretty uncomfortable because it's going to literally push on the knee on one side, close up one side but open up the other and try to make it feel better. It might work for a while, but you're probably going to get sick of wearing it. And it also might damage the skin because it's putting pressure on it. You could end up with sores on your skin and so forth. But the option is there for people that want to try it. The end treatment, that top rung of the ladder, in both categories of your non-inflammatory and your inflammatory, is a knee replacement. So once a knee has been totally destroyed, bone on bone, and you try to do all these other things that make you feel comfortable and to get along, and nothing works, you've exhausted everything but surgery, then you know it's time to do that. Here's that brace. You can see what I mean by it being kind of bulky and big. And again, it's kind of tough to wear things under it and over it. Now here's what a knee replacement looks like when you take the x-ray. So remember I said that the cartilage is there, but it doesn't get picked up by x-ray, so it looks like there's nothing there. So this patient has some cartilage left here, hardly any cartilage left here. So they ended up getting the knee replacement. And these components, this is basically stainless steel on both sides, and in between is plastic, high strength polymer plastic. And that's why that doesn't show up on x-ray, because that is radiolucent as well. I have some models that you can kind of look at. The first one shows a normal knee with preserved good articular cartilage. And then you'll see one that's kind of destroyed, bone on bone, and then the knee replacement. This is pretty much what it looks like. I mean, these are small models, but basically what we do is we cut the ends of the bone very minimally to cut the arthritis out, so to speak, and then reconfigure the geometry of the ends of the bone so that we can put those components in. And there are various sizes because not everybody has the same size knee. So during surgery, we just kind of cut it out and then glue those components with cement on both sides and then put in that piece of plastic.
Since there's still cartilage left on that one side of that knee, would you have to do a full knee replacement? Or?
Good question. What we're not looking at here is a lateral x-ray or an x-ray from the side showing the kneecap. So people can have horrible arthritis under the kneecap too. If you have two of those three compartments that are really arthritic, the best choice is a total knee replacement. If you have just one isolated compartment and you think that there's no pain coming from any other source, you could be a candidate for a partial knee replacement or a uni. That just obviously means one compartment, unicompartmental knee replacement. I'll tell you that the results of those are all over the place. And
Would it be better not to do exercise and workouts?
It's always better to exercise.
Okay.
It's the level of exercise that you gotta weigh in. So anything high impact is not good for joints. Anything that overly stresses it, but it's always good to get your heart rate up, just for your general well-being. Things like low impact, like your elliptical machines, even walking. But when you get into running and jumping, that's when, if those things hurt, then you ought to cut those out. Swimming is probably my favorite exercise for patients to do because it's very low impact, really no impact if you're actually just swimming instead of walking on the with your feet on the bottom. And that uses every muscle in your body. I try to run at least 10 miles a week to somewhat stay in shape. And I'm pretty used to doing that. So I can pretty much run 2 miles without hardly breaking a sweat now. I go into a pool if we're on vacation and I'm playing with the kids and I do a couple laps, I'm out of breath. And I feel like I'm really out of shape. So I know it's just making me work every muscle in my body, and it's just a really good exercise. And it's great for joints because it doesn't load them up.
You can overdo it in running though too, can't you? Because we had a neighbor, he's in his early 20s. He ran 4 miles every day, summer and winter. He's in his early 50s now. He can't even walk. Both his knees are completely shot.
Really?
Just you gotta overdo it.
Yeah, you can. And the main thing is to listen to your body. When you're in your 20s and 30s, sometimes you hurt, but you push yourself through it. I had a friend one time, it's kind of funny that, the saying, no pain, no gain? Well, he'd never exercised because his theory was no pain, no pain. But I thought that was kind of funny. I don't know what kind of shape he's in now, but this was years ago. That's just another picture of a knee replacement. There are subtle differences between manufacturers of knee replacement components, but it's kind of like a car. All cars should have 4 wheels and an engine that makes it go. But then all the bells and whistles and the different types, they're all pretty much trying to accomplish the same thing. And that's to try to make it from bone on bone to metal on plastic, cement them in usually, and try to align the knee as perfect as possible, and to balance the ligaments. So, in other words, you don't want a knee replacement and then someone be able to take your leg and just open it up like this. That would be an unstable knee. So there are things that different manufacturers of these components offer in order to try to make the surgeon's job easier or the outcomes better. But from vendor to vendor, you got your DePuy, your Stryker, your Smith & Nephew, all these different things. There's really not that much difference from vendor to vendor. If there was, and one was better, so much better than another, they'd run the other guys out of business. That's why we have Ford, GM, Chrysler, Nissan, all that. So it's pretty much all the same. Just a little bit
new. That cartilage up there advertises Omega all the time. It's supposed to be so good for making cartilage. Is it anything to it, or?
Well,
Pushing that so much now.
are you talking the fatty acid, omega-3 fatty acids?
Your knees are bone on bone.
Or glucosamine and chondroitin. You've heard of that too. There are studies all over the place. There have been a couple studies done on animals because it's less. You're not going to get what's called a placebo effect by giving it to a dog. Now, if you give medication to a person, even if it's a sugar pill and they don't know it, they might think that it's doing something. And that might trick the mind into thinking that you do feel better. So that's that placebo effect. So some of the animal studies that they've done, they haven't really noticed much of a difference. But then it depends on who you read. Because then if you see Jack Hanna on the commercials, he'll say, give your dogs this because it'll make them feel better and have them more active. The problem with it is that there's not a drug company that has like a patent on it. Like if they make a new medication, they stand to make billions of dollars on it because nobody else can make it. But glucosamine and chondroitin, it's just an off-the-shelf item. And there's not much of these companies don't really want to put much research into it, money into it, because they're not going to really get it out of it, because they can buy it anywhere from anybody. Nobody has the patent or the copyright or anything like that to hold on to the profits. So some people take it and it works wonders, others don't. I will tell you that about 10 years ago, my wife started taking it, glucosamine and chondroitin, and stated that she felt better. And I kind of laughed at her and I said, well, I think it's a placebo effect. And I took it and it didn't do anything for me 10 years ago. Well, last year, she bought another bottle. And then she put it, we take vitamins every day, and so she put them in my spot. And I said, oh, what are you doing? And she, well, just try it. Because I had little aches and pains, from working out and running and stuff like that. And I took it, and I actually did feel better. And I'm thinking, well, is that placebo effect working on me? Or is it really helping? I don't know, but she continues to take it, so I continue to take it too. Because it's there on our shelf. Yep.
Why does our bodies make the cartilage and stop making it or whatever to begin with? I guess I don't understand that part. At what point are we limited to what our bodies are going to make in our lifetime? Or,
Yes.
Or does it constantly replace it or doesn't?
No. Unfortunately, when cartilage starts to degrade, it doesn't really come back. Now, the whole point of the glucosamine and chondroitin, there's a lot of theories on what the mechanism of action is. And some say that if you have a little bit of chondrocytes, those are cartilage cells. If you have a lot of those that are spared and functioning, and you just have little areas of arthritis, that maybe you can stimulate those chondrocytes or the cartilage cells that are working well to kind of not necessarily spread out, but overcome the bad parts, so to speak, and stimulate the knee or joints to make more synovial fluid. That's like a slippery oil. So if you oil the joint a little bit more, maybe it'll feel more comfortable. You're not getting that grinding. If I were to go into your knee and shave off some cartilage, depending on how large it is, it's not going to grow back. So the cartilage that gets destroyed through arthritis is not going to grow back. That's why we need to replace that surface. So the treatments that you have up to that last rung of the ladder, the knee replacement, they're all meant to make it feel more comfortable, decrease inflammation. You've probably seen patients, people with bad arthritis, and the joint just swells up. A lot of fluid in there. Quite often I have to aspirate fluid out. I just did one yesterday that I took 76 cc's out. And that's a lot of fluid. So sometimes the body overproduces the synovial fluid. That's kind of counterproductive. But it doesn't know when to quit. It just knows, all right, this joint is arthritic. I'm going to start throwing more fluid in there and hopefully make it feel better. It just doesn't have the checks and balances depending on how bad the arthritis is. So there's really nothing you can do to stimulate and replace that. they've tried other things too. They've tried to slip like a arthroscopically slip a little shim, like a shim that you would do on a door, and put that right in there. Just kind of shove it in there, and hopefully you're not, it's sliding on that shim surface. Kind of like the same thing as a knee replacement, but just putting it in there and trying to be really less invasive than a knee replacement. And then in the hopes that you're not getting that bone on bone. But you can imagine if you shove something in there like that, it could be wrought with a lot of potential complications. It could displace, it could pop out, it could go in the back of the knee and cause problems with your blood vessels, your nerves. So even though their thought process was good to try, nothing ever really succeeded because it just wasn't stable enough. And it doesn't correct the alignment of the knee either. At least with a knee replacement, we are cutting the bone, and we can try to make that leg straighter. So theoretically, if this patient's going to have a knee replacement, we could go in there and make the bone cuts so that it ends up looking straight like this after it's replaced. And that will ensure a longer life of the components too. Because if you left them off kilter, you could get more wear on one side versus the other. Then the component would need to be replaced. I can't give you a time frame, but theoretically you could shorten the life of the components. You want them as equal on both sides as possible. So there's an artist rendering of before the severe arthritis and then after. I never did like the term total knee replacement because people think that you cut the bone off the thigh and down here and you got a big old hunk of metal like you're the Terminator. But it's really not that. It's more of a resurfacing. I'd rather call it a resurfacing knee replacement because that's really what it is. You can see those components that are going around. They're not that thick.
How long is recovery on that?
If you have a knee replacement, the usual length of stay in the hospital is 2 to 3 nights. We get you moving the night of surgery to at least march next to the bed because those components, once the glue is dried after 5 minutes of placing them, it's not going to get any stronger. So when you leave the hospital, you do have physical therapy at least 3 times a week. And that's to keep it moving. Because as the incision heals, it's going to want to get stiff. You want to combat that. You want to make sure you're getting the leg as straight as possible and bending at least to 90 degrees by 6 weeks. Preferably to 120 by 3 months. So most people are off of pain medication around 6 weeks, 4 to 6 weeks. The incision and the violation of the tissue, because we go through the quad tendon and we go through the soft tissue around the kneecap and right next to the patella tendon, that takes a good 6 to 8 weeks to heal. But most people are back driving within 6 weeks. And this is all a bell curve. That's what the average is. I've had patients be on both sides of the bell curve too. I've had patients that have taken a long time to heal and to feel better. And I've had patients, I'll never forget this one pig farmer that I did down in Viroqua. He basically wanted to jump out of bed right after the surgery and go directly home. And he was about 55, really good shape, but just a destroyed knee. I mean, his knee looked like that on the left, even worse. And when I first saw him, he could hardly move his leg. And he was limping around. I replaced it, and the next morning he says, "All right, can I go home?" I go, well, no, because we haven't even finished. We give routine antibiotics prophylactically for 24 hours after the surgery to decrease the risk of infection. He didn't even finish those out yet. So I said, no, you got to wait at least till tomorrow. So we went, and I think I did his surgery on a Thursday. And he went home on Saturday. He showed up for his first physical therapy appointment Monday outside of the hospital, and he had jeans on. And he walked in, just walking normally. He already had basically full range of motion because he pushed himself during that weekend. And when he walked in, they said, well, where have you been? You must be like 3 months out. He goes, no, I just had it done Thursday. And he said, oh, yeah, you're lying. So he pulled it up, and you saw the scar. And that it wasn't even hardly healed yet, the incision. And so when I saw him at the 2-week, I always see patients 2 weeks later, he said, well, I feel great. I want to get back to pig farming. I go, your soft tissues aren't even healed yet. In 2 weeks, it's going to take 6 to 8 weeks. My fear was he's going to go out, run around, and his wound is just going to fillet open because it wasn't sticky enough. It wasn't healed enough. And he said, well, you did such a great job. Should I advertise for you? And I thought, well, at first my knee-jerk reaction was, yeah. And then I thought, well, wait a minute, no. Because this is totally abnormal. And I don't want people to think that they should be in like your shoes and feel great 5 days after the surgery. I go, most people it takes 6 weeks. So I actually didn't want him to tell anybody. But that's the gamut that you have. And then you have some people that don't do well at all.
Why is that?
So there's so many reasons. Some people, it's just their ability to heal.
Do they baby it? Or?
Well, for stiffness, yeah, I find that a lot of people don't want to. There's a difference between being uncomfortable and having pain. It's definitely going to be uncomfortable for you to push that knee while it's healing. If you think of it like if you have a laceration or a cut in your hand, and you don't want it to necessarily heal up to where it's real stiff. So you don't necessarily pull it apart, but you just kind of gently manipulate it a little bit so it doesn't form a very quick scar that's really stiff. That's the best analogy I can come up with. So some people don't even want that uncomfortable feeling of playing around with a cut. I'm not saying that you want to pry it apart because that would be painful. But that's what you need to do. When you have a knee replaced, you need to get it moving. So that because if you just don't do anything, it'll scar up, heal up, and it'll just shrink. And then you're going to need what's called a manipulation. So if you come to me at 6 weeks after a total knee replacement, and you can't bend it any further than 80 degrees, I'm going to suggest that we do the manipulation. And what that is, it's very simple. We numb the leg up in the OR, and then we just push right through and we break up that scar tissue. It sounds bad, but there are some potential complications, like if you have to do it too hard in someone that's osteoporotic, you could potentially break a bone. But thankfully, I have not had to do it since I moved here, and I attribute that to good education for the patients to get it moving, the fact that the patients are very motivated too. I use a little bit, I use custom patient instrumentation, which means that we get cutting blocks that are unique to your anatomy. I don't know how much of it is that, because there's a lot of things that factor into someone getting a stiff knee. But down in Viroqua, I'd say 10% of the patients, maybe not that many, maybe 7% of the patients needed to be manipulated. And usually they feel tons better after it's manipulated, because you're dealing with a really stiff joint, and then we get it moving, and then we take them right to physical therapy twice a day. Just keep it moving. Don't rest. Keep it moving, and then people usually come back and say, "Oh, I feel so much better now. I can move."
Well, is some of that possibly carried over from prior to the surgery, from the stiffness of the joint?
It can
Over the
be.
years?
Yep.
You know how not using it properly over the years, or exercise and stuff?
There's a big shift now to do prehab. Before you have the surgery, do physical therapy to get your muscle strength and everything as tuned up as possible, and then have the surgery. And I haven't seen any results yet, because this is kind of a new thing. But we might see that is a good thing to do, to increase the positive outcomes. But, only to a certain extent, I would think. People with bad arthritis, I've done patients that come in and they can't move their knee at all. And they've just been dealing with it, didn't want to have surgery. And then when I get done doing their knee replacement, I might get them, I know this one gentleman I'm thinking of, he came in and he was flexed. He couldn't straighten his leg. He could only move it from the 20-degree flexion to about 40. That was it. That's all he could do. And in surgery, it took forever because it was so tight to try to loosen up the ligaments without making them unstable. Like I said, sometimes you can loosen up those ligaments so much, then it becomes unstable, and then you got to do a different type of component to rein it in, so to speak. But anyways, I spent, his surgery took me about 3.5 hours, which normally they're about an hour, hour and a half. And when I got done, I could get him fully straight, but I could only get him to about 90, 95 degrees. And then I was hoping that he would be able to do that on his own too. This was on the table. And sure enough, he worked pretty hard, and he was maintaining the full extension, and he got to about 90. And to me, I want you to be 120. So here I'm thinking I have a failure here, but I could only do so much. And he was happy, very happy. In fact, so happy he wanted me to do the other one. So, and the other one was a lot easier. We did the first one the other one had somewhat normal range of motion. But it's all relative. He came in, if someone were to look at him and, you just had knee replacement 3 months ago and you're only getting from 0 to 90, that's not that good. But then you have to look at what he was before. It's a world of difference. It changed the fact that he had to climb upstairs one at a time to now he can just do them normally. And that alone he was happy with. There's an old saying in orthopedics that you can't make a chicken out of chicken soup. So we do the best to make it better, but sometimes we're dealt with something that we can't make it perfect. Any other questions?
Just some of the things that you're talking about here about the knee, can you apply them to like the shoulder?
Absolutely.
Because I don't really have any knee pain, but I have a lot of shoulder pain. It's right shoulder.
And shoulder pain, the main thing is if you're experiencing pain in any joint, any particular area of the body, is it get evaluated and get some x-rays. And then that way, the number one thing is to come up with a diagnosis, obviously. So the shoulder, tons of things can cause shoulder pain. It doesn't necessarily have to be arthritis.
This came on suddenly. I think I lifted too much about 3 months ago, and it isn't getting any better, but I can't say it's getting worse.
Okay.
It's probably the worst when I just lay in bed.
Rotator cuff tears, tendonitis, a condition called impingement syndrome, bursitis, arthritis. All these things can contribute to pain. So the main thing is to do the proper exam, get imaging studies. If the x-rays look good, you might need an MRI, because the MRI shows those other structures where the x-rays don't.
So the fact that it hasn't got any better in 3 months means I should go in and have a look at it.
Yeah, depending on what your tolerance for pain is.
It isn't so bad during the daylight time. Pulling up isn't bad, but you gotta get your hand above your head, that's.
Okay. Yeah, that could be a lot of things, and if it bothers you enough, I'd get it checked out.
Cortisone don't do nothing, it's something more drastic than that, huh?
There are other things other than cortisone. I had it listed, but I didn't talk about it. The chicken fat shots, people call them, rooster comb or chicken fat shots. The one that I use, there's a bunch of different brands out there. Flexa, Synvisc, Kyalgan, all these different types of brands. Basically, they're all about the same. One of them on the market is synthetic, but the others are derived from rooster combs. And the generic term is viscosupplementation, and that is FDA approved for the knee. So we can inject that viscosupplementation into the knee. It looks like a jelly, a clear jelly. And the thought process is it goes in there and kind of coats the end of the bone and hopefully stimulates the knee to make just the right amount of oil to make it more lubricated and feel better.
At the rooster comb?
Yep. And none of these things are guaranteed, obviously. There is a trend now, though, as more research comes out, they're thinking that rooster comb, Synvisc, or viscosupplementation is not all it's cracked up to be, because they've been now comparing it to bigger, larger groups of patients, and they're not really seeing that it's having that much of an effect. But I continue to use it because I have some patients that say it works. And again, I don't know if it's a placebo effect or if it's really doing something chemically to make them feel better. And truthfully, I don't really care as long as the patient gets better. So if you feel better flapping your arms like a chicken, then go ahead and do it. But as long as you don't do something that could potentially cause harm.
With a separated shoulder, that's my big problem. My one shoulder just kills me, but my shoulder's separated. I never had nothing done with it many years ago.
Okay.
And it's just killing me now.
Your
I had
AC
cortisone and it doesn't do any good anymore.
Your AC joint was separated?
Yeah.
Yeah, that's, you could have potentially arthritis there because of the separation.
What can you do? Can you put a new joint in or something? Or can
Well, if that is what's causing your issue, again, you should be evaluated, examined, x-rays taken to make sure that that is the culprit and that's the problem. If the injections haven't helped, there is a procedure that can be done where we just shave off that end of the bone. That is not a big load-bearing joint in the shoulder. So we can do what's called a distal clavicle excision. All that means is the end of the collarbone is cut right off, just about ½ centimeter. And usually that takes care of the pain, because what you're getting is you're getting that bone-on-bone rubbing. And then if we just cut that bone off and there's nothing in there, you don't get that. And you don't run the risk of the shoulder becoming unstable because it's just a minor joint in that shoulder that's not meant to really be loaded. So there's a lot of different things we could do.
I have a possible ski injury on my ankle, and I wasn't sure, I had gone through physical therapy, and now a year later, it's ski season, and I'm not sure if I should do it. And I'm just not, I don't know which avenue to go to, because I went to a sports medicine doctor before, and now the pain is still there, and I don't feel as agile as I used to. So I don't know if I should be seeing an orthopedic or what the next step should be.
It all depends on, well, the big question mark is the insurance. Sometimes insurances require you to go to primary care doctor, and they're the gatekeeper. You need a referral or what have you for them to try to keep costs down. But if you don't have that roadblock, I would suggest seeing an orthopedic surgeon. That way you kind of cut out the middleman, and they can examine you, take x-rays, and kind of figure out what the main problem is and treat that accordingly. There's a lot of things that we can do for that. Therapy, anti-inflammatories, injections, and all the way up to surgery.
And if it's muscle related, is there a separate doctor for that?
It all depends on what the diagnosis is. And some people are, I mean, your body is a continuum, and it's all connected. There have been patients that come in and say, I have horrible knee pain, and I get x-rays of the knee, and it looks better than mine. And then I examine them, and I find the knee is perfect. Great range of motion, no swelling, no tenderness when I push on things in the knee. But as an orthopedic surgeon, I know I got to look at that whole lower extremity. I even have to look at the back, because you could have a disc out, pinching a nerve, and it shows up as knee pain. So you got to make sure that you do a good, thorough exam to try to pinpoint what the proper diagnosis is, and then go after that. This one particular case, total just 100% knee pain. And then I took her leg, and I tried to move her hip, and it would not budge. She could go out like this, but she could not go in at all. And that's one of the signs of horrible arthritis of the hip. So we got x-rays of her hip, and she looked at me like I was a Martian. My hip doesn't hurt. Why are you doing that? It's a waste of money and waste of time. I go, well, I think you might have some arthritis in there, because I see how this doesn't move? And then look at the other side. It moves. I didn't notice that before. I said, do you mind if we get him? Oh, all right, go ahead and get it. Bone on bone. She had a hip replacement, and her knee pain was gone. So that's why it's very important to do a thorough exam. Any other questions? Okay, well, thank you for coming.
I've
Go
got
ahead.
one related to the hip again.
Mhm.
Actually, I saw you last year on diagnosis of mild osteoarthritis in my hip.
Mhm.
Just how fast can that progress, for one? And is there, relating to previous conversation of the nerves and where the pain might be coming from, is there any swelling involved also with that? And is that swelling anywhere near the nerves that would control functions in my muscles in my leg? Because I'll get muscle pain, just sharp occasional stabs, let's say.
Okay.
Are they related, or?
Less likely. So your first part of the question is, can it progress and how fast? It can definitely progress, but how fast is related to your level of activity and the genes you've been given.
Okay.
Sometimes it takes a long time for it to go to stage. There's basically stage 0, 1, 2, 3, 4. Okay, so 0 obviously is just normal. 4 is bone on bone. So how long it takes to get from like 1 to 4, everybody's different. Some people could be in 1 forever and never reach 2, 3, or 4. So that's a big variable. The swelling, there's inevitably some swelling in the hip joint. The hip joint is pretty forgivable because it's very deep, and it doesn't allow for much swelling because it's a ball and socket that are really tightly locked together. The knee is a bigger compartment. The knee is basically like a balloon. So you can fill up a balloon with water, and the knee can expand. You can see some knees that come out just like a basketball. But the hip is a different story. You can get a little bit of excess fluid, but not much. And it usually, I can go on a limb and say pretty much that it's not going to swell up enough to cause compression on a nerve in that area. Yours might be just like a myositis. That means inflammation of the muscle at that location, or it possibly could be referred pain from a back issue.
Risk of infection And also the risk of rejection, is that pretty high?
I've never had a patient reject a knee. I've had patients come in that were done elsewhere and may have had a little sensitivity to nickel. And I had one patient undergo a revision and it did get better, but that is very, very rare. And then the first part of your question?
Risk
was
of infection from a surgery like this?
Generally nationwide, it's about 1 to 2%. So if we did 100 joints in a day, 1 to 2 of those are going to get infected. And you never know who it's going to happen to. We try to decrease the chance of that by a number of things. Certain techniques in the OR, prophylactic antibiotics. We give you antibiotics right before we start the procedure, and we give you antibiotics after the procedure for 24 hours. That's been shown in the literature to be pretty effective in decreasing the chance of an infection. The other thing you're relying on is someone to have just good protein in their body, just be healthy. Diabetics have a higher rate of infection, so you have to keep a keen eye on those patients. You want them to have their sugars under control. I've had a lot of patients that I've had to postpone surgery because their sugars were out of control. So I always have a patient go through a history and physical from their primary care doctor to make sure they're safe for surgery. And sometimes they come back and they say that their hemoglobin A1C, I don't know if anybody is diabetic here. Their hemoglobin A1C is just a marker for how high your sugars have been over the past 3 months. And if you're averaging 120, 140 of your sugar, which is okay, your hemoglobin A1C would reflect that and be low enough. So I had one patient had a normal hemoglobin A1C, or a good one, is around 6. I've had them come back as 10 or 11. And that, on average, is blood sugars of 250 or 300, way out of control. And the higher the sugar content in your blood, the less likely it is you're going to heal, and the higher chance of infection. So some of those patients are not happy with me because they still deal with the knee pain, but I tell them that I cannot do their surgery in good conscience until they get that blood sugar down. Because as mad as they are at me now that I'm not doing it to make their knee pain better, if I knowingly do surgery when they're not tuned up properly and they get an infection, that's worse. You get an infection in a total joint, you have to take all the components out. You're on IV antibiotics for 6 to 8 weeks. You've got to make sure the infection's gone before you implant a new one. And what's worse is if that infection keeps coming back and you just can't get rid of it for whatever reason, some of those patients need an amputation. So they went from trying to get a knee replacement to feel better, and they chronic infection, and they end up with an above-knee amputation. So it's not to be taken lightly, and that's why we want patients tuned up as best we can.
Person has more difficulty going down set of stairs versus up set of stairs. Is that indicative of anything? Or?
That's pretty normal.
Okay.
Yep. That is normal because you have a little bit more control when you're going up. The muscles that you're contracting and so forth, and the fact that you're probably holding on to a railing, you've got just a little more control. When you're going downstairs, you have gravity kind of forcing you down further, and it's a different, you're contracting different muscles that kind of counteract severe arthritis. Okay. Hopefully it was beneficial for you, and I'll stick around if you want to ask me anything individually. Thanks for coming.
Thank you, Doc.